Hello, I'm Dr. Rosen, and I want to thank you for coming to the conference today. And this, as you know, is ultrasound for the liver, gallbladder, and pancreas. Now, for those of you who are relatively new to ultrasound, I'll just give you my personal bias. I think clinically the ultrasound exam for the liver and gallbladder are quite important in the emergency department and in the intensive care unit as well as general medicine. The examination of the pancreas is somewhat more difficult, and we'll get into that in the lecture. CAT scan is the gold standard test for looking at the structure of the pancreas. The pancreas can be somewhat difficult to visualize, and you really need to know your landmarks. So when it comes to ultrasonography, gallbladder, the examination is crucial, liver, super important. Pancreas, it's nice to know. But just realize that ultrasonography does have its limitations. But additionally, flip side, ultrasound can still be useful. Well, let's get into it now. So, as most of you know, there are many different types of probes. So, to examine the organs that are in question here, we're going to use a probe that's a low frequency where we can look at deep organs. So we're going to use a phased array probe or a curvilinear probe. So the P17 or P21, beginning with P for the word phased, and the C60 in this case, another low frequency probe, beginning with the word C for curvilinear. And these probes, again, as a general rule, we all know, typically point to the patient's right or to the patient's head. And we're going to be examining the organs in either longitudinal, transverse, or coronal planes, and typically you want at least two of these views. So what I do is, for examining the heart, I look at the liver first and then find the heart. For examining the liver, I look at the heart first and then move to the liver. So since we're talking about the liver, I'm going to locate the heart, which is relatively easy, and then slide over to the liver. So we put the probe in the subxiphoid position in the longitudinal plane, and we'll see the right tip of the liver with the heart. Then we'll slide the probe down to the margins of the right ribs, and we'll visualize the liver and gallbladder. Now, occasionally, it can be difficult to visualize the liver and gallbladder from this angle. Sometimes the patient has a lot of gas, and you can't compress all the way through the gas to see the gallbladder. And sometimes the patient's obese. In that case, going to the coronal view on the side is particularly useful. Now, when you go to the coronal view, you really need to think about what probes you want to use. I happen to prefer phased array probes for the gallbladder. Many people prefer the C60 probe, the curvilinear probe. But when it comes to doing a coronal view, you're going between the ribs. So the curvilinear probe has a larger footprint and can fit between the ribs as well. So many people would prefer at this point to switch to the phased array probe, which can more easily fit between the ribs. Your choice, but just remember you have to deal with the ribs if you go to the coronal view. So first we'll start off with a subxiphoid view. Now in this clip we see the liver at the superior part of this image, and then the heart surrounded by pericardial effusion. We now have our landmark where the liver is, and we just slide down to the right ribs to see more of the liver and the gallbladder. Now remember that when we go from the superficial anatomy, the skin and the subcutaneous fat, and we go up to the level of the chest, since we're aiming the probe up, the beam is going up, the image will appear on the bottom of the screen when it's further into the body. So as we go up away from the probe, we're going down on the image. In other words, the top of this screen is skin and subcutaneous fat. We then traverse the liver. On our way up towards the head, we hit the diaphragm. And over here we see the inferior vena cava labeled as such. Now the liver is a very vascular structure, which helps differentiate it from any picture that has a diaphragm and a liver-like structure in it, which could be spleen. Very avascular compared to the liver. Sometimes you can't see all the vascularity, but just by changing the axis of the probe by 5 degrees or so, you can get this image. Now in this image, we have the liver marked with the green arrow, and we have the hepatic veins draining into the inferior vena cava at the inferior aspect of this image. And the hyperechoic structure at the bottom is of course, the diaphragm. And obviously, this could not be mistaken for a spleen. So again, skin, liver, IVC, and diaphragm, with the ultrasound beam going from the top of the screen going down. And if you think of how the beam is aimed on the patient, it's going from the skin up to the diaphragm. Now here's a clip of the spleen, which is rather large, and you'll see typing appear on the left side of the screen saying big spleen. And note the lack of vascularity in the spleen. And on the slide you can see also the question, can you see the kidney fluid in the splenorenal pouch and the general ascites? So the kidney is at the inferior margin of the screen. It'll appear shortly. You can see the hyperechoic space between the spleen and the kidney, and there's the ascites on the right of the image. Now, when we think of a patient who has cirrhosis, on physical exam, the liver is shrunken, it's hard, it's nodular, and we can see signs of that on the ultrasonographic exam. So as the liver shrinks and scars, with cirrhosis it becomes hyperechoic, relatively avascular, with a scalloped edge. And over here is a cirrhotic liver, the green arrow pointing to ascites, where it's anechoic. And the kidney, the space between the kidney and this cirrhotic liver is Morrison's pouch, and there's obviously fluid in Morrison's pouch because of the massive ascites. And here's an image of a very typical cirrhosis patient. And again, notice that the liver is exactly what you would expect to feel on physical exam. Small, shrunken, nodular at the edges. And you could imagine that this would be a firm liver, hard liver. Not hard, but firm. This is an image of a 34-year-old who had fevers in Honduras and had some right upper quadrant pain. Gallbladder was normal, but this was found on the patient, and it was quite tender to palpation with the probe. This is a very large, somewhat cystic structure that measures over 5 centimeters at this margin here. And this was drained in the hospital and proved to be an infected liver cyst. It's a different patient, 51 years old, with abdominal pain and weight loss. And you can see from this clip, you can hardly even tell this is liver. There's no vasculature. The architecture of the liver is completely off, and you can make out these gross nodules. And this is a patient who has cancer of the liver. And in various aspects of this clip, you can see hypoechoic areas, and that's fluid that is collected from the ascites related to this liver cancer. Now, here's a mass that was found on an ultrasound. And as you can see at the bottom left of the slide, it measures 6.1 centimeters by 5.87 centimeters, so approximately a 6 centimeter mass. This patient came in with right upper quadrant pain, and an ultrasound was obtained at first looking at the gallbladder. Well, how was this liver mass found? So here's the ultrasound of the gallbladder. Here's the gallbladder here. The walls are somewhat thicker than normal, as we'll find out, but as we fan through the gallbladder, we can see that at a certain point, the mass appears. And there it is. That's the mass in the liver. So the moral of the story here is, when you're looking at one structure, don't ignore the surrounding structures. There's a reason why this patient has a thickened gallbladder, and that's due to the ascites, which we can see here. And there's a reason why this patient has ascites, and that's not due to his gallbladder disease. That's due to the liver cancer, which was proven by biopsy of this nodule. This mass, actually, not a nodule. Now, the most common reason by far, of course, of looking at the gallbladder is to rule out acute cholecystitis. So what do we look for? First thing is we want to see if the patient has stones. And if he doesn't have stones, is there sludge? Sludge is basically sand in the gallbladder rather than what amounts to a pebble. And it has a sand-like quality not only when you're in the operating room, but also radiographically and sonographically. And then we look for fluid around the gallbladder, or pericholecystic fluid. We measure the anterior wall of the gallbladder, which is normally less than 3 millimeters. If it's greater than 3 millimeters, then the gallbladder wall is thicker than normal. Why is it thicker than normal? As with any inflammation, gallbladder can get edematous. And when the gallbladder has enough edema, some of it weeps around the gallbladder, and that gives the pericholecystic fluid. And we'll see later why we measure the anterior wall of the gallbladder. There's a lot of artifact on the posterior wall. Then also we'll measure the common bile duct. The internal diameter, not the external, but the internal diameter, so you exclude the walls, should be less than 6 millimeters until age 60. And then we add 1 millimeter per decade, so less than 7 millimeters until age 70, less than 8 till age 80, and so forth. Now we can change the depth of field. If we look over here, this is at 15, and look at the gallbladder here. Now as we change it, here it is at 11. Much more clear view, and we can see this fold in the gallbladder. So by changing the depth of field, we can make the object significantly easier to examine and to make measurements. An important point is trying to make the diagnosis in the face of acute cholecystitis in the face of ascites can be quite problematic. Ascites, by definition, will have pericholecystic fluid. There's fluid all over the place. And since the gallbladder wall is capable of absorbing fluid, ascites will cause thickening of the gallbladder wall. So there are two things that will help. One is to measure the diameter of the common bile duct. If it's enlarged from an obstruction, that certainly hints extremely strongly towards your diagnosis of acute cholecystitis. And the other is check for a sonographic Murphy sign. So we all know Murphy sign, where you give somewhat of a small punch to the ribs over the liver, and if it hurts, not just where you're hitting obviously, but it hurts inside at the gallbladder, that's a positive Murphy sign for acute cholecystitis. Well, if you're looking at the gallbladder with the transducer, with the probe, you know exactly where the gallbladder is. So if you take the probe and push up against the gallbladder, a positive Murphy sign means that the patient has significant pain on doing that. Now there's a button on every ultrasound machine which can freeze the image. So this image is frozen here. And now someone here is attempting to measure the anterior wall of the gallbladder with great difficulty because they don't have a good image of the anterior wall. So they're going to take another picture here, another image. And here we can see in the longitudinal axis a very clear gallbladder wall that we can image on the anterior surface. And remember, this is anterior because here's the skin, and this is going more and more posteriorly. And now if we look at the posterior wall, we can see that this posterior acoustic enhancement, all of this extra shadowing here, this extra hyperechoic areas, you can't measure the posterior wall very easily. And that's why we measure the anterior wall. It's not because there's a difference between the two. It's that the posterior wall is just very difficult to measure. Ascites can cause thickening of the gallbladder wall. In this image, we have ascites, free fluid over here. And looking at this gallbladder wall, we can actually see there's a strip of hypoechoic fluid within the wall of the gallbladder here. The gallbladder wall is significantly swollen. Again, it should be less than 3 millimeters. This appears to be approximately 7 millimeters. And we don't need calipers to measure this over here. We can just compare it to the 1 millimeter hatch marks over here. And this is more than half, certainly. It's more like 3/4 of one of these hatch marks, so probably about 0.7 millimeters. Gallstones should have shadowing. This clip shows a very large gallstone. Here's the gallbladder here, and the gallstone is at the tip of the white arrow, and then posterior to that is the shadowing of the gallstone. As the ultrasound beam comes down this direction, it hits a solid mass, the gallstone. It can't penetrate past it, so over here we have the shadowing, where the ultrasound beam just cannot be. Now, other things can cause shadowing as well, and you want to be sure that you realize that shadowing, which is a very good way to locate a gallbladder, as we'll see in some other cases, shadowing is not always due to gallstones. So in this case, I purposely have a clip which shows the gallbladder over here and shows the shadowing right next to it over here. It's not from the gallbladder. This is caused by the duodenum, which is just a little bit posterior, a little bit deep to the gallbladder, and it's in a slightly different plane. So I actually like to use shadowing to help me locate the gallbladder. Sometimes if you see shadowing, you trace it up and it's a gallstone. Other times you see shadowing and it ends up coming to a structure and you say, it just doesn't look like the gallbladder perhaps, and you realize that's the duodenum. And if it is, then you say, all right, I know this is just posterior to where I want to be, go a little bit more anterior, and lo and behold, you typically find the gallbladder. So this is a pretty good slide, which is unusual to find actually, a clip like this. Usually don't see the duodenum so swollen here, but here's the duodenum posterior to the gallbladder over here. And you can see that there's peristalsis within the duodenum. So if you're not sure if you're looking at the duodenum or the gallbladder, look for the peristalsis. So a few points. Gallbladders can be in variable locations, and they may have incidental folds, as this one does. We illustrated this before. Examine the gallbladder in more than one plane. So you want to have a transverse and a longitudinal plane. And gallbladders typically have posterior acoustic enhancement over here, which makes it difficult to measure the posterior wall, and that's why when we measure the wall thickness, we go to the anterior wall, which again would be difficult in this particular view because we don't see it very well. If you can't find the gallbladder, there are several things to do. In days of yore, it was very easy to see that the person had an open cholecystectomy and there was a huge scar. With the advent of laparoscopic cholecystectomies, sometimes the scars are hard to find. So be sure that the patient has not had a cholecystectomy. Have the patient roll to the left side if the patient's able to, and just as with the examination of the heart, the examination of the gallbladder is significantly easier. The heart is brought close to the surface on the left lateral decubitus. The gallbladder kind of rolls out of position from under the liver and moves more anteriorly for your probe. If that doesn't work, you may want to try an X-7 position. So what does that mean? X stands for xiphoid, which begins with an X. So you go to the tip of the xiphoid process, 7 centimeters laterally to it, towards the right, and you take the probe and just go anteriorly 7 centimeters from the xiphoid process and aim straight down posteriorly between the ribs, and that's usually about the place where the gallbladder lies. The other thing that you can do is try imaging from a coronal view, and that's particularly helpful in a patient who's overweight. Now here's cholelithiasis. Gallstone's over here, and then you can see the shadowing. One important thing to look for is what's called the double barrel shotgun sign. And that's the common bile duct anteriorly, the portal vein posteriorly, and it looks like a shotgun. 2 barrels, one on top of the other, and they both lead towards the gallbladder. So in this image, you can see the gallbladder is labeled, and the common bile duct is the space between the 2 orange arrowheads, and the portal vein, the space between the 2 truncated yellow arrows. The double barrel shotgun sign of the common bile duct can be seen here on this clip. And over here is the CBD, or common bile duct. And more posteriorly is the portal vein. Portal vein typically significantly larger than the CBD. And again, we would measure the diameter of the CBD from here to here, the internal diameter, and not from the outside to the outside. As you can see, that would be a significantly different measurement. Over here again, this illustrates at the tip of the arrow the space between the two A's with the curses is the CBD, and we measure the interior wall. In this case, you can look on the lower left-hand side of the screen, and it measures 0.36 centimeters, so significantly less than the 0.6 centimeters. So this is normal. And the gallbladder is in the upper right-hand corner, the anechoic structure. Now, this to me is a somewhat depressing day for me. I found this image recently, and I said, my goodness, this would be great to incorporate this into the lecture. It's from an atlas that I used in medical school. But then I didn't want to do it because of copyright issues until I found out that the image is so old that, alas, I'm old enough that the copyright no longer is in effect. So I can use this image courtesy of Gray's Anatomy. So we thank Gray for his lovely diagrams. At the green arrow over here, what do we see? Correct, gallbladder. And over here, this is a structure that is talked about in medical school, and we sort of forget about it somewhat. I really use this to help identify the gallbladder with ultrasonography, and this is the interlobar fissure. And you can see the gallbladder arises right out of the interlobar fissure. And not only that, but over here is the portal vein, and that enters in the into the interlobar fissure. So let's take a look at how that helps us. Over here, this is the MILF, the median interlobar longitudinal fissure. So at the blue line, you can see this hyperechoic structure, which seems to connect the gallbladder to another structure, which is the CBD, the common bile duct. If I can't find the gallbladder and I see this longitudinal structure, the MILF, I know that at the end of it, I will find the gallbladder. So it's a great landmark. Likewise, if I find the gallbladder and I want to measure the CBD, if there's a MILF, I know at the end of the MILF, on the opposite side, I'm going to find the CBD. This over here is a rather remarkable MILF, a giant MILF, usually not seen this way at all, but interesting nonetheless. Now, as we said before, gallstones typically have shadowing. Again, the ultrasound beam comes down, hits the gallstone over here, cannot penetrate over here. One of the buttons on the ultrasound machine that we tend not to pay attention to is the degree of penetration. So over here, this is the typical default setting, general. Now let's look at this image. This is something that I don't normally use. This is the res mode, the resolution mode. So this is for more superficial structures. It doesn't penetrate as well. Same probe, but you're using a higher frequency. So over here is the gallbladder. Very difficult to see stones. And shadowing, which isn't very clear. So if we change from the res mode, or typically the gen mode, and we go to the pen or penetrating mode, same patient, and now you can see the gallstones and very clear shadowing. So when do I use this? I use the penetrating mode or the pen mode in an obese patient where I can't visualize structures as well as I would like. You don't get a very clear image, so this is not unusual in terms of quality, but you do get very good penetration. So it's a trade-off again. You're able to see what you want, but just not as clearly as compared to I can't see what I want at all. Just something to think about for the obese patient. All right, here's an important sign to remember, and that's the West sign. So we know that ideally patients should be NPO past midnight for an ultrasound exam. Why? Well, if you eat something, particularly if it's a fatty meal, the bile will be released by the gallbladder. The gallbladder contracts, and you can't see the gallbladder as well. In this case, we have the gallbladder that's contracted around a stone. We don't see a big gallbladder. We see over here the wall of the gallbladder. Over here is the echo of the stone. And over here is the shadow that's cast by the ultrasound beam unable to penetrate. So wall, echo, shadow. That's the West sign. Now this is an unusual clip that I've just showed you in terms of clarity. Normally, the West sign is not this apparent. So this is a more typical West sign. Much more subtle, but this is actually how it typically looks. So again, you could have a very hard time in saying, I wonder where the gallbladder is, I'm not exactly sure, and then all of a sudden you see the shadowing over here. So you say, all right, well if that's shadowing, let's follow the shadowing up to its apex. And there's the apex. And there's a little hyperechoic dot up there, and in fact, that's a stone. The gallbladder has collapsed around it, and that's a West sign, wall, echo, shadow. But be careful not to confuse this with the duodenum. You can see how easy this would be to think that it's the duodenum, and it's just particles of food that are in the duodenum and are causing shadowing. Well, how do we know that this isn't duodenum? Well, first of all, we've looked all over and we can't find the gallbladder. But something else. Over here, we see the CBD. And over here, we see the portal vein. So we have the shotgun sign, the double barrel shotgun sign, and the stone right on top. So in this particular case, the shadowing was in fact very useful. And I use this commonly. What's seen here on this clip? What's at the tip of the arrow here? Right, that's ascites. And over here, very good, that's a cirrhotic liver. And you can see it's not just a liver, but it's contracted, it's hyperechoic, and virtually no vasculature. If it wasn't for the fact that you have this over here, you might think it was the spleen. And this over here is the gallbladder. Now, do we see this gallbladder as very clear, black, totally anechoic? No. There seems to be a grainy quality to it. And that, in fact, is sludge. It's grainy because, in fact, it's sand. What about this gallbladder? Is this gallbladder abnormal? All right, let's take a look. There is sludge at the tip of the yellow arrow. You can see it. The question is there a stone here? So there's a very subtle finding. Look at the shadowing. At the yellow arrow, do you see it? Right there. Now it's very difficult to see in this view, but over there, there's actually a gallstone, a hyperechoic stone. And we did another view on this patient, and we were able to see it more readily. So this is actually a gallbladder that has sludge and a very small stone in it. Now, before we move to the pancreas, we have to review the structure of the aorta because we use some of the anatomical structures of the aorta to locate the pancreas. So as the aorta descends through the diaphragm, we can examine it in a transverse plane right below the xiphoid process. And that's the origin of the celiac artery. And very close to that, slightly inferior, is the SMA or superior mesenteric artery. And then if we go down further, once we hit the umbilicus, that's about the level where the aorta bifurcates. So before we look at the pancreas, with the abdominal probe, in a transverse position sliding down in this fashion. Let's look here, and we see a seagull. Easy. Now what about a seagull's anatomy? There's the seagull's common hepatic artery, and on the opposite side, there's the seagull's splenic artery. Okay, why do we care? Because over here are the wings of the seagull sign. That's the celiac axis just below the xiphoid process. And it looks just like a seagull with a common hepatic artery on the right and the splenic artery on the left, coming out of the aorta, right below the xiphoid process. If you go down a centimeter or two away from the xiphoid process, more inferiorly, you'll miss it. Now, as we go down slightly below that, we come to the level of the SMA. And we recognize that by a variety of structures. So first, there's the vertebra and the vertebral shadow behind it. And now, there are several vessels that we can recognize, and I'll label them all at once here, and we'll go through them slowly. So we know that the aorta sits right on top of the spine. So on the left side is the aorta, on the right side is the IVC. Makes sense anatomically because the heart is on the left side, gives rise to the aorta. The IVC is on the right as it moves up toward the liver. Now just above this is the SMA, the superior mesenteric artery. And that's been described as a mantle clock. So if you think of a clock that sits on a mantle with a little face for the clock face is the SMA, and the mantle shape is the fat around the SMA. And the splenic vein crosses on top of the superior mesenteric artery. In this particular view, the splenic vein is crossing, as we see it frequently, going in and out of the plane of the view, so it almost appears as if it's two veins, when actually it's one. But this is a very common view, and I wanted to show this. Now over here is really a more perfect view, kind of a textbook view, where you see the splenic vein as one solid vein. So let's go through the structures here, and then we can use this to help locate the pancreas. So over here is what? Correct, that's the vertebra. And between these two lines, the spinal shadow. Then we have some vessels. Over here, the IVC. And what's this over here? The aorta. Now we have the mantle face on the clock right there. That's the SMA. And over here is the splenic vein. Now where's the pancreas? If you look around the splenic vein, the way I imagine it is think of the splenic vein as a lake. The shore around the lake, that's the pancreas. So take a look at the right side of the lake, the top of the lake, the left side of the lake. And now here's the pancreas, right above the lake. Let's look at another image. The head, neck, body, and tail. The head is above the IVC. The neck typically above the aorta. The body tends to course above the splenic vein, and the tail is frequently difficult to see as it fades in towards the spleen. Right on top of the body is the stomach, and right next to the head to the right is the duodenum. But the landmark of the splenic vein coursing across the SMA is the money shot for finding the pancreas. Now let's look over here. There's your lake, and that's the splenic vein. There's flow on this that was placed by somebody to say, is that the vascular structure? And the answer is yes, it is. And now we can see that here's the splenic vein, and there was a question by the resident who did this about this structure over here. and they thought this was the duct of Wirsung, the pancreatic duct. And the answer is no, I don't think it is. Why? Because if you look at the margins of the pancreas, it seems to come across here, and then it comes down over here. So this is outside the plane of the pancreas. How is this duct going this way when the pancreas, we know, slides down this way? And then if we go back again over here and take a look, this comes out of the plane of the pancreas over here. This, you can actually make out the edge of the pancreas here. So this, what's in this direction? We know duodenum's over here. We know spleen is over here. Up here is stomach. So this is coming from the stomach, I believe. And now we'll see again vascular. Well, they were thinking the duct isn't vascular, but neither is the stomach. So let's conclude with some take-home points. We may have to relearn some basic anatomy, especially when it comes to locating the pancreas. The ultrasound is, I think, somewhat hard to learn from lectures. I enjoy giving the lectures, but it's so much easier once you get a few good views with the hands-on session. So I want to leave a lot of time for everybody to have practice with the hands-on sessions. We can change the depth of field or the position to enhance visualization. And for the gallbladder, remember that the duodenum has that shadow that is sometimes seen that can throw you off. But the shadow is also very good to follow if you're looking for stones. Don't forget the West sign, and don't forget the MILF can also help you. And the pancreas, remember, is located by anatomical structures.